approaches. And we hope that we are focusing now on some systematic approaches like ExpandNet, Improvement Collaborative, the Fostering Change, but we know that there are many others out there, and we would like to share knowledge on all of those. Also, most importantly, we'd like to hear from country programs or projects that have scaled up family planning successfully. We'd like also to review some existing guides and tools to support scaling up. For example, recently the Fostering Change Guide was revised, and we, the Community of Practice and IBP, took the lead in sharing it with many of the partners. And we feel that the Community of Practice goals and objectives contribute to the IBP goals and their results framework. So that's why we work very closely with them. And if you haven't signed yet for the Community of Practice, the link is shown below, and it was also sent in the invite so that you can join us. So now moving to today's discussion on those series for learning series on costing for scaling up. The Community of Practice has organized 3 webinars. Today's webinar will talk about the rationale and introduction to methods for costing the scale-up of family planning programs. So this is sort of an overview, and we will come to the objectives very soon. And then on webinar 2, we will dig deeper into models and tools for family planning costing for scaling up, and we have presenters from other organizations covering this one. And then the third webinar will focus on principles of financing for scaling up family planning program, because the resource team discussed this and said, okay, so we work on costing, we understand it, we know how to do it, but then where does the money come from? And therefore we need also to talk about principles of financing. So for today's webinar, I'll just share with you very quickly our learning objectives. And as I mentioned, we have 2 speakers for today. We hope that by the end of this webinar, the participants would be able to understand the rationale for costing scaling up, why is it important, and then differentiate between costing for scale up and costing for pilot projects, because there are many differences there. Hopefully, the webinar will give you an overview of the methods and tools for costing pilot projects and how to use your results to estimate the scaling up costs. And our second presenter for today will focus mainly on costed implementation plans as a platform for incorporating costing for scale up, so that this becomes part of the national family planning programs. So now I'd like to present our guest speakers for today. Both guest speakers come from FHI 360. We shared a short bio in the invite, but please allow me to introduce our first speaker briefly. The first speaker is Jean Bratt, a scientist, health economics in FHI 360's Program Sciences Department. His research focuses on economic aspects of health programs in low and middle income countries. Specific topics include costing of interventions and services, cost effectiveness, and estimating resource requirements associated with scale-up. Now, before I give the floor to Jean, I'd like to mention that you are free to write your questions in the chat box. I think you can see it. It's in the sort of bottom of that panel in front of you. And feel free to write your question either to the presenter or to the whole audience. We prefer, so it's better to write it to the whole audience so that people interact with the questions. At the end, we will select some questions to respond to. And if we could not answer all of them, we will send the responses later. So, but please bear with us because I'm still working on the adding more participants to the webinar. And 1 second, and the floor will be to John. And attendees. Okay, John, I just unmuted you, and you are ready to start. So the floor is yours. Go ahead.
Okay, very good. Thank you, Salwa. I hope everyone can hear me. I'm glad to have this opportunity to speak today on estimating costs of scaling up. Programmatic research looking at interventions in global health has tended to focus on measuring effectiveness. But the topic of value for money is becoming more prominent in the global health agenda, and this is helping to drive interest in costing interventions and estimating costs of scale-up. So first, let's review some reasons why you might want to estimate scale-up costs. The first reason is very profound. You'll all be amazed at how profound this reason is. Because somebody inevitably will ask you, how much will it cost to scale up this program or intervention? It's always the first question that you hear after demonstrating that some idea, intervention, or program has been effective. And it's good to have an evidence-based answer that's based on some transparent analysis to respond. But there are some other reasons as well. First of all, providing stakeholders with meaningful information on costs of installing an intervention at scale may help with resource mobilization. So if you can tell potential funders what it would cost at scale, this can be useful in getting them to agree to fund it. Secondly, if resources are already committed to scale-up estimates provide structured guidance on the resource requirements. So it can help to begin the process of activity budgeting for the scale-up process. And finally, just because an intervention is effective doesn't mean that it's financially feasible or sustainable. So estimating scale-up costs can help stakeholders to avoid spending scarce resources on an intervention that may wind up being unsustainable at scale. FHI 360 has developed an approach to estimating costs of scaling up that is really quite simple. First of all, we know the best evidence about costs relevant to scale-up comes from the pilot project itself. So we measure costs of the pilot project prospectively during implementation. That's the preference. Secondly, we work with stakeholders to specify how the implementation of the program or practice at scale would differ from the pilot project, and we'll talk more about this later on in the presentation. And finally, we translate these adjustments into cost terms. So let's focus on some technical details briefly around costing pilot projects. First, which costs should be considered? So many interventions that ultimately become best practices often begin as small pilot projects carried out within a larger program. And in family planning, there are a lot of examples of this, many of them particularly in the integration field, where we've seen family planning integrated into MCH programs, HIV programs, and other non-health programs such as microfinance. So when we're costing a pilot intervention, the cost of the existing program doesn't really apply. The focus is on the incremental costs that come with the intervention. Also, it's useful to have a way to structure and classify intervention elements to break down the cost of an intervention into smaller parts to make it easier to see the transparency of the costs and where the costs are coming from. So we have this economic taxonomy of an intervention. We begin with the phase of an intervention, and most interventions that we work with have three main phases. There's a planning phase. There's a second phase where you're putting into place the resources needed to carry out the intervention. We call this preparing for service delivery. And the third phase is the initial period of service delivery itself, when the intervention is, we're burning it in, essentially. Now each phase includes a set of activities. For example, in the planning phase, we would have planning meetings, and in the preparing for service delivery phase, we often have workshops and trainings. And then activities, in order to carry them out, require resources, and those resources have costs. So this is a useful way to classify intervention elements. When we cost out a pilot intervention, we follow a standard process, which would be familiar to any of you who've done any costing. We first identify the resources used for each activity, and these can break down into the broad categories of labor, supplies, and capital. We then measure these resources in their natural units. So for labor, we would measure the number of hours used. For supplies, the number of items, and we could also be looking at days of per diem in the case of workshops. We then assign a unit value to each resource, which is the process of attaching a price or cost to the resource. And then at the end, we add up all of the resources, multiply them by their unit costs, and that then gives us the total cost for an activity. So for example, let's imagine we've got an intervention and we're looking at the preparing for service delivery phase, the second of the three phases that I mentioned. And here are four illustrative activities that we might have. A training of trainers, then those trained trainers would go and train community-based agents in a central location. There might also be some activities to improve the supervision system, and we might also be looking at improving the logistics system for commodities. Now let's focus a little more closely on one of these activities to illustrate some of what I've already talked about. So here's an illustration of how we might go about costing an implementation activity, in this case the trainer of trainers. I'm sorry, the training of the community-based agents. We see the different resources listed down the left-hand column. We see their measurement in natural units in the middle column, the quantity, and the unit cost, and then finally the total cost. And it gives us a grand total, which is, in this case is $2,868 for one of these trainings. So now if we go back to look at the total cost of this phase, we see that it's comprised of a trainer of trainers workshop, 3 of these CBA workshops, the supervisor training, and the logistics upgrade. So the total cost of this phase then is $11,339. So this shows you kind of in a discrete example how we actually go about doing this. And you can also see that it looks quite similar to what we refer to as activity budgets. And people with experience in constructing activity budgets also can very easily be trained to do this kind of work. So now we're going to transition from looking at the costs of the pilot to estimating costs of scaling up. Now, many times people new to this way of thinking about scale up will ask a question, isn't it easy? Can't we just take the number of sites that we're thinking about scaling up to and multiply that by the costs that we measured in the pilot? So for example, if we had a pilot project that we measured the cost per clinic to be $2,500, the incremental cost, and the plans were to scale it up to 40 clinics, can we assume that the cost would be simply $2,500 times 40 clinics? This seems to make intuitive sense. But we're here to tell you that no, we can't do this. Scale-up costs are not simple multipliers of the cost of pilot projects. And I'll explain this in more detail. You see on the left side of the screen, this is a publication that FHI 360 contributed to when we were a partner on the Frontiers project. And this publication, which you see the URL down at the bottom, you can obtain it for yourself, it summarizes the points that I'm going to talk about. So there are 4 main reasons. First of all, that there are some components of the pilot that are not repeated in the scale-up. Secondly, we can encounter economies of scale. Thirdly, there can be differences in the entity providing inputs in the scale-up as opposed to the pilot. And finally, there can be changes in the intervention content or program between the pilot and the scale-up. And I'll cover each one of these in more depth. First of all, pilot components not repeated in the scale-up. So a good example of this is in the planning phase, where planning for the pilot intervention, you might actually carry out activities that would also could be exploited in the scale-up, and you wouldn't have to repeat them. So some planning elements are one-time activities that don't need to be repeated. If your pilot project included the design of a curriculum, for example, a training curriculum, that curriculum could probably be used with minimal changes in the scale-up, and so that cost wouldn't be repeated in the scale-up. Secondly, often to carry out a pilot project, you need to get stakeholder buy-in at high levels of a national health system. And so once the Ministry of Health has given its blessing to the pilot project, oftentimes when you're ready to scale it up, you don't have to go back and ask for approval again. So those costs wouldn't be included in scale-up costs. Secondly, economies of scale. So the definition of economies of scale is a reduction in cost per unit resulting from increased production and operational efficiencies. So for example, you might have trained 10 individuals per training in a pilot workshop, but you could actually train 30 individuals per training in the same type of workshop in a scale-up. We know that pilot project budgets often are dictated not by economic efficiency, but more by just resource availability. And so oftentimes we find that you can be more efficient in a scale-up and train more people per workshop, for example. A third example is differences in the entity providing inputs. So when a donor-funded institution like one of our cooperating agencies implements a pilot project, sometimes we use international consultants to do initial training, and they may work through a local training contractor as well, and these international consultants tend to be quite expensive compared to the Ministry of Health staff who might be in charge of taking the innovation to scale. So when you substitute these lower cost resources for the higher cost resources used in the pilot, this obviously makes a difference in the cost of scale-up. Also, sometimes in pilot projects, we have resources that we don't have to pay for. There might be donated resources, donated commodities, for example. And so in this case, non-financial costs in the pilot might become financial costs at scale. It might be that once the project is scaled up, we have to actually pay for those resources that were provided for free in the pilot. Finally, there can be changes in the intervention between the pilot and the scale-up. So it might be that the scale-up chooses to emphasize certain activities based on relative effectiveness and or changes in priorities that were discovered in the pilot. And so as the mix of activities changes, so will the costs of scaling up this modified intervention. And also sometimes there are activities in the pilot that are deemed to be not financially realistic at scale. And a good example of this is that often in our pilot projects we put quite intensive supervision as one of the pilot elements. And when the intervention is scaled up, that same level of supervision likely won't be provided, and so in that case too the pilot cost would be different than the cost of scale-up. So finally, here are some messages to take home. First of all, there are increasing calls to justify interventions and programs on value for money criteria. It's not enough anymore just to show that something's effective. Secondly, that disaggregating the cost of a pilot project gives us the information, the evidence that we need to work with stakeholders to estimate scale-up costs. Scale-up costs are not simple multipliers of the cost of pilot projects, and that estimates of scale-up costs have many practical uses beyond the obvious one, which is to just answer the question, what will it cost to scale this up? Thank you very much.
Okay. John, thank you so much. It was a very clear and to-the-point presentation. And now I'd like to present our second guest speaker for the day. And please, you can, as I mentioned, you can start writing your questions in the chat box while I'm preparing Christine. So let me introduce Christine Lasway. She's a senior technical officer with the Research Utilization Unit at FHI 360. Her work predominantly involves providing technical assistance to countries to translate, scale up, and institutionalize research evidence into policy and practice. Christine is the technical focal point for Costed Implementation Plan, CIPs, at FHI 360, and has successfully led this effort in many countries. So I'd like to welcome Christine to present on Costed Implementation Plan. And Christine, the floor is yours now. Sorry, Christine, you were muted, so the floor is yours now. Go ahead.
Thank you, Sawa, for the introduction. For this last but not least segment of the webinar today, I'll be providing you with an overview of costed implementation plans and how costs for scaling up are featured in CIPs. To start with, let's talk about what costed implementation plans are. CIPs contain cost estimates of multi-year action plans with clear measurable outputs for achieving a goal of a family planning program. Most of the time, the goal is the target contraceptive prevalence rate to be achieved in a specified time frame. CIPs can be developed at different levels of the health system, including the district, provincial or regional levels, and national levels. Most of the CIPs today are at the national levels. CIPs are becoming an important buzzword these days, especially in the context of FP 2020, as often they represent the country's action plan to meet their FP 2020 commitments. CIPs are an important indicator for the FP 2020 Performance Monitoring and Accountability Working Group. CIPs were first developed in Tanzania in 2010 after stakeholders there decided that to make sense to ongoing advocacy efforts, there was a fundamental need to clearly articulate costs associated with repositioning a family planning program. Furthermore, it was thought that the CIP would maximize collective impact and improve coordination of the family planning program across multiple stakeholders. To date, 9 countries have CIPs, and so far it's been proved to be an important tool for costing a family planning program, but also a tool for monitoring and accountability. What are the functional purposes of costed implementation plans? They serve multiple functions, including being an implementation roadmap for a family planning program, describing priority results, targets for programmatic inputs required, and key interventions to be implemented. It also represents a budget. There's several national family planning programs that really do not have a budget for the entire family planning program or interventions needed to be able to achieve their contraceptive prevalence rate. And the CIP definitely addresses that issue. It also acts as a performance monitoring plan, specifying benchmarks and indicators to monitor implementation as well as resource mobilization. Furthermore, it supports the government as a planning and management tool to effectively coordinate activities implemented by multiple stakeholders. And lastly, it is an advocacy tool for advocating for resources, as well as recognition of family planning or inclusion of family planning indicators in the national development agendas. So in the context of the topic for this webinar today, if you think about it, CIPs are really pieces of puzzles brought together, with each puzzle representing a costed scale-up plan for a specific intervention. In addition, in putting these pieces together, instead of in different plans, there's also the benefit of economies of scale across scale-up plans of different interventions. For example, trainings or guidance documents could be bundled up instead of developed separately. Furthermore, CIPs include or incorporate other key elements that will support scale-up of an innovation. For example, enabling environment or commodities. For example, if you're scaling up community-based distribution of DMPA, then the increased need for DMPA vials would already been considered and planned for in the commodity projections. Also in the context of scale-up, the CIP also provides a basis for monitoring and evaluating scale-up of innovations at national scale. Based on our experience working in Tanzania, Kenya, and Senegal, we here at FHI describe the process of developing a CAP as involving 5 steps in a highly collaborative and participatory environment involving various stakeholders at country level. These 5 steps are elaborated in detail in the resources sent with the email announcement for this webinar. So I'll just briefly go over them. The 5 steps include first, seeking to set the purpose and direction of the CIP. Then step 2, assessing the situation and needs for the program. Then based on a clear understanding of the situation and needs, you will proceed to step 3 to define and prioritize interventions. Here in step 3 is where discussions regarding which innovations to scale up come into play. Then in step 4 includes costing of the interventions that have been prioritized. Then finally in step 5 is implementation and monitoring. So for step 1, setting purpose and direction, we have found this to be a very crucial step in providing the foundation and guiding principles for the process. Several questions you want answered at this stage include: who are the end users for your costed implementation plan? The primary end users of a costed implementation plan include the government, development, and implementing partners, including the private sector. Identifying and agreeing on the type of audience for the CIP is important from the onset because the type of audience dictates the content as well as the costing estimates to be included. The second question is, what are the institutional arrangements for implementing the CIP? This is a very similar concept that we face when we're developing scale-up plans. This implies the institutions responsible or accountable for undertaking the CIPs to be identified from the onset and lead the process for its development. The second step involves assessing the situation and needs. It is important that a CIP be grounded on a solid understanding of the factors that drive or block progress towards achieving family planning goals. This second step aims at understanding the status and performance of the essential components of a family planning program, determine demographic determinants for resource requirements that will be costed later in step 4, as well as generating key strategic considerations that inform the decision-making process. Some of the key questions to answer in this step include: what are the key issues at various levels, including supply, demand, enabling environment concerning the implementation of the family planning program? What is the needed annual change in CPR by age or geographical area? And what are the current intervention strategies that could be expanded or should be expanded, etc. After having a very solid understanding of the situation and needs, we move to step 3. In this step, we basically define and prioritize interventions to be undertaken. The outcome to be achieved here is essentially a log frame ready for costing, including a detailed description of interventions action plan with targets to be achieved. This process also involves prioritization of interventions using a clearly set and agreed upon criteria. Examples of the criteria may include the potential to increase contraceptive prevalence rate, feasibility of implementation, and the fact that interventions are evidence-based. Again, this is very similar to what we look at when we are developing scale-up plans. The fourth step is generating cost estimates. This is pretty much very similar to what John described earlier today. It involves generating costs for the different activities based on defined inputs and targets. Here's an example of a scale-up activity of integrating family planning into MCH services, where activity-based costing is used. As you can see, the process or activities, as well as the inputs and the targets, are clearly described, resulting into the cost estimates for the activity. This process is repeated for all activities and then collated to determine the total cost amount for basically achieving the contraceptive prevalence rate target. Then we proceed into the fifth step, which is implementing and monitoring implementation of the CIP. For monitoring for this fifth step, it involves assessing progress in mobilizing financial resources for implementation of the activities as well as program implementation. A monitoring plan with indicators and process for data collection and analysis is developed to support this step. Here's another example of a scale-up activity from the Tanzania Costed Implementation Plan, with annual program targets as well as financial targets for resource mobilization indicated. Every quarter, program and financial expenditure data is collected against this indicator, number of people trained by district, to assess progress against the specified targets. So essentially, these are what we call the 5-step process to developing a CAP. It is important to note here that the 5th step is not the last step, and that this process is not necessarily linear, but cyclical. Data generated from monitoring exercises is used to inform progress, gaps, or areas that may need further attention, leading to a need to reassess the situation and/or rethink interventions. I have a few take-home messages for you with regard to CIPs and costing for scale-up. The first one is that really CIPs can be viewed as a collection of multiple costed scale-up plans. Scale-up of innovation can be supported as part of a broader strategy to achieve a country CPR rather than a standalone plan. And CIPs can help support resource mobilization strategies for scale-up plans. Thank you.
Hello, Christine, thank you so much. It was a lovely presentation, and I'd like now to open the floor for questions. If people have their questions, they can write them down as we mentioned in the chat box. In the meantime, I think I muted John, so let me just unmute John so that he can also be, oh, John, I think you muted yourself, so you need to unmute yourself. Yes. Yes, you're good to go. Okay. So the first questions that I'd like to ask that came when we were preparing for this meeting, and sorry to put the first question, but while waiting for others to write their questions. So John and Christine, from your perspective, our resource team members said that it seems there's lots of experience in costing the actual implementation of an activity, and you mentioned many examples of those, the training, the curricula, the commodities, everything. But the question was, how do you cost the management side? Because it seems we focus mostly on the implementation aspect, but not on the management aspect. And I'd like to hear your views, both John and Christine, on this costing of the management aspect, because it goes neglected in many costing exercises. So who likes to start?
Oh, I'll be happy to. We have included the management aspect in many of our costings. It's included as another activity that can cut across all the phases of the project. And so, if we know who the implementer is and we can talk to the people at the level of the implementer who are doing the overall management, who are making sure that all of the pieces are being rolled out on schedule, then we can talk to them, we can ask them to estimate what proportion of their time they're spending on that, and if there's any travel or other sorts of sub-activities that are included in that, and then we can apply that to the intervention cost in the same way that we measure the cost of other activities.
Okay, thanks, John. Christine, do you like to add your ideas from the CIP point of view? Christine, did you mute yourself?
Yes, I have unmuted myself. Yes. The management aspect is partially included, I would say. And for the CIP that I've mostly worked on is in Tanzania. And there, the government only wanted to include incremental costs, the additional costs for the intervention per se, and did not include the salaries, like the labor required resources, etc., because that is something that they felt that's covered already. So there's, in the health systems management strategic action area, there is some costs that have been included for management of the intervention, but that's assumed that's covered already.
Okay, well, thank you, Christine. Thank you, John. So the second question is, I think people, the participants and us here, we feel that we need to know more about the challenges that you face when developing the costed implementation plans, or even, John, from your perspective, the costing itself at the country level. Can you share with us some realistic challenges and how were you able to address those challenges? Christine, do you like to start?
Yeah, I can talk about the challenges with costed implementation plans. First of all, the process is highly collaborative, highly participatory. It involves multiple stakeholders, so which is a very good thing because you do want to have buy-in from the beginning. However, that means that the process can be extensively long, but also there's a lot of logistical and coordination issues to take into consideration. The second challenge is the inadequacy of data. For developing this plan and the plan to be evidence-based, based on sound data, you need to find, for example, baseline data for projections or unit costs to be able to estimate your cost items. And it's not that easy to generate or to be able to secure this information. So those are the kind of challenges that we have faced at country level.
Okay, thanks, Christine. John, do you like to add something about the challenges on your side?
Yeah, I would echo a lot of what Christine said about data availability. But I would also say there's a bigger challenge, and that is that costing interventions and programs is not yet risen to the level of an expectation where funders and other authorities say that this sort of information isn't just nice to have, but it really should be required in these cases. Many of our partners are not accustomed to being asked for cost information. What they're used to is being asked to show how well something works. And then the assumption is that if the program or the intervention is effective, that a funder will come in and pay for it. But I think increasingly what we're seeing with the scarcity of resources in global health and other development sectors, that's not necessarily the case. And my own view is that we should adopt an approach more like in many commercial sector enterprises where when you're preparing a project plan or you're preparing a proposal for scaling something up, that you need to have a section on what are the financial implications of this, where will the financing come from, what are the expected costs going to be at scale, and that this should become routine information that is expected when these sorts of plans are presented.
Okay, thank you, John and Christine. There's a question and a comment. Of course, comments are saying that the presentations are great, so congratulations. And then the question says that they found the steps very useful when developing national plans in a country for many other interventions such as immunization, vitamin A, but the participant would like to know about the role of coordination of logistics for scale-up. So the focus is on logistics for scale-up in costing FP plan and whether this would keep the cost down.
Sure. So logistics is always a big element of any kind of program like this. And it's oftentimes a part of the program that when it breaks down, obviously the program can't function as it's designed. So coordinating logistics is very important, and like all other elements of the intervention, a clear plan needs to be in place with clear targets and processes. And that also can be costed out. When the activities are made explicit and when the resources within those activities are made explicit, then it's much better in terms of planning, because you know ahead of time what the likely costs of an activity like trying to coordinate logistics will be.
Okay. Christine, do you like to comment on that?
No, I think that what John said is sufficient.
Okay, thank you. So we're moving to another question, and this time it's on M&E. And the participant is requesting you to share some challenges of monitoring the implementation of scale-up using the CIPs.
Okay. In terms of particularly monitoring of implementation, it's not a challenge in the context of that you have indicators and you have targets very clearly outlined. What becomes a challenge, of course, is being able to get everybody to report on what they're doing, because you're working with multiple stakeholders. Oftentimes, not everybody is reporting because so there is inadequacy in reporting, but also because with scale-up of interventions, it involves different institutions, and sometimes different institutions choose certain geographical areas compared to others. Sometimes you don't achieve the optimum geographical coverage that's needed for scale-up. We've often seen this where you will find the geographical areas that really need to be covered by the intervention are not covered, and you go back and discuss that situation, but that doesn't get addressed. Another issue is financing. The targets are high, and being able to mobilize adequate resources to cover them within a specified time frame is definitely a huge challenge.
Okay, thank you, Christine. So a question is about the timeline for costed implementation plans in some of the countries where you worked in, and also the government's endorsement of costing in general and costed implementation plans, like little bit on the endorsement and how did you use this for advocacy and for systematic scaling up?
Okay. On the timeline, and I'll talk a little bit about government endorsement. Of course, at this day and age, it's easier because of its inclusion in FP 2020. So it's much easier adapted in different countries. Like I mentioned before, Tanzania was the first country to do this, and the government actually was the one in the forefront wanting it to happen, because they were not clear as far as how much it costed to be able to reach their national target. So we didn't really face many challenges as far as getting endorsement of the idea of the CIP. The challenge was when we presented the cost estimates, which was significantly high, and in the context of competing priorities and budgeting, we had to convince that the budget represent not only the government budget, but also all different stakeholders that are involved in family planning. So that, as far as endorsement is concerned, was a little bit of a challenge there in terms of convincing the government to accept the cost. In fact, it ended up being reduced significantly from the original budget.
Okay. Okay, and the timeline, like, is it a lengthy process?
Yeah, it can take from 6 months to a year to develop it, mainly because of high stakeholder involvement.
Okay, so we have another question about, I think you touched a little bit on it, but the question is about how you decide on the prioritization, and for example, is it based on the cost effectiveness of a best practice or an intervention? Like, how do you prioritize those interventions from your experience?
Mm-hmm. Okay. Well, I talked about value for money at the beginning of my presentation. And if you break that down, the value piece refers to what the intervention or the innovation produces. And the money piece refers to what the cost of producing that innovation would be. So when we cost out a pilot project, we're collecting all this information to guide scale up in case the decision is taken to scale it up. But we're also measuring in some way, what did the pilot project produce? You know, what was the indicator of success or of productivity or of output that we were measuring in the pilot project? And so we make an effort to try to relate the incremental costs of the intervention to the incremental output of the intervention, and that gives you a sense of value for money. It gives you a sense of, at least in the pilot project, what did we get out of this program for the resources that we put into it. So that information can help decide whether or not it's worthwhile to move forward with scaling up an intervention. And in some cases what you find is that you'll invest a lot of resources into an idea that seemed like a good one, and you'll find that it doesn't move the needle very much on what you were trying to do. And so you can say that for the resources that were invested, that it looks like the value for money is not particularly impressive. We rarely are able to do a true cost effectiveness assessment because that requires at least 2 interventions to compare, or it requires some sort of criterion that is agreed upon in terms of what level of cost per unit of output is considered to be cost effective. And we don't have a lot of those in reproductive health. In other areas of health economics, you'll see a lot of analyses looking at disability adjusted life years, and that allows you then to set thresholds of cost effectiveness. But we don't tend to do that much in our work.
Okay, well, thank you a lot, John and Christine, our presenters, and also our participants for your for hanging out there with us and your rich questions. And for now, I just like to apologize again for the technical difficulty we faced, and that we only were able to have 26 participants join us. And we'll work on the second webinar. We'll work through a different system that would allow us to get more participants. Also to share the presentation and the questions with the people who could not join us. We're trying to record it, and we will share it with the other people. So for now, I'll just announce our next webinar. I don't have a date yet for the second webinar. We're still working on that. But as I mentioned before, we will talk more about models and tools for family planning costing. And with that, I am closing this webinar. Thank you very much, everybody, and goodbye.
Thank you.
Yes, goodbye. Thank you.
Bye.